Welcome. My name is Helen Gilburt and I'm a fellow in the policy team at the King's Fund, where I lead our work on mental health. I joined the fund in 2013 and my background is involved conducting research and analysis, as well as supporting the delivery of advice and information on mental health care and policy for more than 20 years. The King's Fund is an independent charity working to improve health and care in England. We do this through conducting research and analysis to support policymakers and those planning and delivering services, supporting developing leadership within health and care organisations, bringing people together to share ideas and thinking on new ways of delivering health and care, and supporting people to understand how health and care services work. Our work on mental health has included understanding the changing nature of care through deinstitutionalisation and the local-led transformation of services, exploring factors influencing the delivery of mental health care, such as workforce and funding, and bringing together national data and insights to support and share wider understanding about the delivery of mental health services. The breadth of our work and focus on mental health policy, alongside an understanding of the wider structures and systems which frame the delivery of care, supports our ability to provide a national overview of that care over time for the inquiry today. This seminar has been put together to provide the inquiry team with an overview of the key legislation, policies and guidance which frame mental health care between 2000 and 2024. It aims to provide a national picture rather than covering policies, structures and arrangements at a local level. It's important to note that the content is not exhaustive. Rather, we have identified key policies, often with a focus on time points at which policies were first implemented, or when there was a notable change in requirements or direction. In addition, there is a focus on policies relevant to the content of the inquiry, in particular on inpatient services. Content for this seminar was informed by the input of clinical and practice experts alongside members of the inquiry team. The seminar and slides are structured to cover the following content: structure of the NHS, key mental health policies and plans, legislation, regulation and accountability, and data and funding. First, we'll look at the structure of the NHS, role of government, and arm's length bodies. During the period covered by the inquiry, there have been three key pieces of legislation which have led to restructures of the NHS. These are important because they define the various bodies, their functions and roles. The following slides outline how the wider NHS structures have changed over that time. Firstly, we're going to look at the NHS organisational structures for commissioning and providing healthcare. The slides show changes over time. Rather than a hierarchy, the structures from top to bottom of the slides can be seen as serving different functions, operating at a national, regional and local level. In 2000, the start of the entire inquiry time period, the NHS Executive, which was part of Department of Health, was responsible for national strategy and policy. Health authorities received allocations for commissioning health services at a regional level, of which primary care groups ran as subcommittees, commissioning services for local populations and monitoring delivery. NHS trusts, alongside independent sector providers and the voluntary sector, then delivered that care. In 2002, NHS Reform and Healthcare Professions Act led to a restructure of the NHS. Health authorities were replaced by strategic health authorities, managing performance and implementing national policy at a regional level. Primary care groups came together to form primary care trusts. They commissioned all local services, including specialised services such as forensic inpatient and children and young people's inpatient care. NHS trusts were able to apply to become NHS Foundation Trusts. Foundation trusts have greater managerial financial autonomy compared with NHS trusts. To apply, trusts had to meet requirements related to governance and financial sustainability. Over time, the majority of trusts became foundation trusts, providing care alongside independent sector providers and the voluntary and community sector. From 2007, a national body was set up to take responsibility for commissioning specialised services, with primary care trusts now focused on the commissioning of local services. 2012 with the Health and Social Care Act led to another restructure of the NHS. Strategic health authorities and primary care trusts were abolished. The NHS Commissioning Board, known as NHS England, was set up. It set policy and guidance for healthcare and picked up the national role for commissioning specialised services. Clinical commissioning groups were formed to commission all local services. From 2015, there was a move towards greater collaboration across local areas supported by a planning framework for NHS services. Sustainability and transformation partnerships were formed, which brought together NHS organisations and local authorities to develop plans for providing care for local populations. Although they were not statutory bodies, policy during this period orientates around them. From 2020, NHS England supports the development of NHS provider collaboratives in mental health. These are groups of trusts and healthcare providers who NHS England delegates the budget and responsibility for commissioning specialised services to at a local level. In 2022, the Health and Care Act creates a final restructure of the NHS. Clinical commissioning groups are abolished and integrated care systems are formed. These built on sustainability and transformation partnerships to become statutory bodies. They comprise of the integrated care system, which brings together organisations to plan for the health of their population, and an integrated care board, which is responsible for commissioning healthcare. Legislative changes have also influenced the NHS organisations which develop policy and hold organisations to account for the care they provide. In 2000, policy making was led by NHS Executive within the Department of Health, with regional offices which fed into local health authorities, alongside individual policy departments in Department of Health, including mental health. Following reorganisation of the NHS in 2002, the functions of the NHS Executive were absorbed into the Department of Health, and alongside its policy department, it sets national strategy and policy. In 2002, the National Institute for Mental Health in England was established. It was responsible for overseeing guidance and implementation of government policy. Alongside it sat the National Institute for Clinical Excellence, which develops national clinical guidance, and the National Patient Safety Agency, which was responsible for monitoring patient safety in NHS-funded care settings. The Commission for Health Improvement inspected healthcare provided by NHS providers, and the National Care Standards Commission inspected and regulated care provided by independent sector providers. Furthermore, in 2004, Monitor was established to licence and regulate newly formed NHS Foundation trusts. Some of these bodies have evolved or were reorganised over time. Notably, the National Institute for Mental Health in England became part of the Care Service Improvement Partnership and later was replaced by the National Mental Health Development Unit. The Commission for Health Improvement was replaced by the Commission for Healthcare Audit and Inspection, which also took on the role of regulating independent sector provision. This body was subsequently replaced by the Care Quality Commission. At the bottom, you will see are the strategic health authorities. While they're not responsible for making policy, they were key for implementation of national policy at a regional level and managing performance. So as an overview, during this period, policy was set by the Department of Health and the National Institute for Mental Health in England and its successors, which also supported implementation and improvement. The National Institute for Clinical Excellence, or NICE, contributed to this by setting clinical standards through its guidance. The Commission for Health Improvement and its successors monitored if providers met regulations and standards, but only the Care Quality Commission had the power to enforce changes across both NHS and independent sector providers. Monitor also acted as a regulator for the finances and governance of foundation trusts, while the National Patient Safety Agency aimed to provide a coordinated mechanism for capturing and learning from patient safety incidents. The Health and Social Care Act in 2012 saw the establishment of a number of new bodies. As you will have seen, the NHS Commissioning Board, known as NHS England, was initially responsible for commissioning specialised services. It also oversees funding, planning and delivery of transformation and performance of NHS healthcare in England. The Health and Social Care Information Centre was established to provide information and data for the day-to-day management of healthcare. Health Education England was established to provide leadership for education, training and workforce development in the health sector. And Public Health England was established to improve the public's health and reduce health inequalities. It did this by delivering specialist public health support functions such as information intelligence, providing leadership for public health, and supporting the development of public health workforce. It played a key role in policy on suicide prevention. Over time, there has been a rationalisation of national bodies, as you can see, with the organisations and their functions being incorporated into the structure of NHS England. We're now going to look at the strategies and policies related to the delivery of mental health care. This is an overview of the high-level strategies which frame delivery of mental health care during the period the inquiry covers. The National Service Framework for Mental Health was published in 1999 and set out a 10-year plan for the development and delivery of services for working-age adults based on 7 quality standards, including suicide prevention, access to services, and services for people with severe mental illness. The National Service Framework, alongside new guidance on care planning, revised the existing approach to implementing what was known as the Care Programme Approach, or CPA. CPA aimed to ensure that there was a full assessment of a patient's needs, that a care coordinator would see that care was delivered, and there would be regular review of the care plan. Patients were designated under standard or enhanced CPA, dependent on their level of needs or complexity. The subsequent NHS plan outlined wider plans for modernising the NHS as a whole and included funding to fast-track implementation of the National Service Framework for Mental Health. The National Institute for Mental Health oversaw implementation of the National Service Framework, developing a series of policy implementation guides and supported at a local level by local implementation teams. Although government published a further vision for mental health in 2009, the next strategy in 2011 reflected a move away from the national specification of services and a drive towards improving care based on outcomes. These would be measured through the use of national outcomes frameworks that commissioners and national bodies could use to assess progress. In 2014, the government set out actions and additional investments over the next 2 years to introduce access and waiting time standards in some community-based services by 2020. The government subsequently set out a vision for improving children and young people's mental health. The vision includes a number of ambitions which are described as cost neutral and could be taken forward, while others required funding and implementation was subject to subsequent government spending reviews. Both the final two national policies reflect a further shift in approach. The 5-year forward view aimed to deliver rapid improvements in outcomes by focusing on a number of priority areas. Similarly, the NHS long-term plan focuses on a smaller number of service areas in addition to supporting large-scale transformation of community mental health services guided by the Community Mental Health Framework. This describes how community mental health services can better meet the needs of people with severe mental illness. The NHS long-term plan also ends the use of care programme approach, with the exception of use in perinatal mental health, adult eating disorder services and adult secure services. Both of these plans were supported by implementation plans which outline targets for the expansion of access, funding allocation and workforce requirements. At a national level, funding for the 5-year forward view was predicated on the basis that investments would generate significant savings and efficiencies. National strategies and plans have been accompanied by mental health policy related to specific populations. This was particularly notable during the period of the National Service Framework and included national policy on care for people with a diagnosis of personality disorder, which set an expectation that trusts should develop appropriate services, but with no explicit requirements around the provision of inpatient care. The same year, guidance was issued on meeting the needs of women within mental health settings. The guidance outlines specific expectations around the delivery of single-sex accommodation, provision of perinatal mental health care, and actions to address patient safety, privacy, and dignity. The National Service Framework extended existing work and set an expectation that young people under the age of 18 should have access to age-appropriate services. Delivering race equality in mental health care is the first guidance within the timeframe which focuses on racial inequalities in care, outlining new training requirements for staff working in mental health services, including clinicians and managers. Best practice in managing risk was published to support services to adopt a more systemic approach to risk assessment and management, and to embed risk management in day-to-day practice, including as part of care programme approach. The guidance provides best practice points alongside tools to support implementation. The next policy of notable relevance is transforming care. This is the start of a programme of work to review the care of people with learning disabilities and autism within hospital settings, with the aims of providing appropriate support for people in the community wherever possible. The final policy to flag is Advancing Mental Health Equality Strategy. One of the core components is the Patient and Race Equality Framework, which aims to embed anti-racism as part of the day-to-day practice of mental health care. In addition, there is a focus on the collection and use of data and diversity and representation in the workforce. In this slide, I want to draw your attention to some of the policies and types of guidance which frame delivery of inpatient care. First are the clinical guidelines issued by the National Institute for Clinical Excellence. Many of the guidelines cover best practice in relation to care for specific conditions. Expectations of care within inpatient settings often form a component of this. In addition, there is specific guidance which relates to the experiences of mental health care and to transitions of care between inpatient and community settings and care homes. Guidance is also issued in response to legislative changes. For example, this is the statutory guidance that was published in relation to the Mental Health Unit's Use of Force Act. Health building notes provide best practice guidance on the design and planning of new healthcare buildings and on the adaptation or extension of existing facilities. Again, this is just one of several examples. Some guidance sets out national specifications for inpatient care, for instance, on addressing requirements around single-sex accommodation. The Royal College of Psychiatrists has run a national accreditation programme for inpatient mental health settings for a number of years. As part of this, they issue standards which provide staff with a clear and comprehensive description of best practice. The first standards for adult inpatient settings were published in 2006, with the guidance updated on a regular basis since. Finally, I want to draw your attention to the Acute Care Declaration. The declaration outlined expectations of good quality acute mental health care and seeks to champion the development of high quality inpatient services. The declaration was signed by a number of organisations, including the National Mental Health Development Unit, the NHS Confederation Mental Health Network, which represents most mental health trusts, and the Royal College of Psychiatrists. There are a number of themes which frame policy and guidance across the time period of the inquiry. These themes are reflected both within national plans and subsequently through specific guidance and planning documents. One of those themes is on the elimination of mixed-sex accommodation. Below is an example of policies and guidance issued over time which reflect the aims of eliminating mixed-sex accommodation and providing safety, dignity and privacy. As such, relevant themes are reflected in new guidance, the ambition is extended, and some guidance is updated as the nature of an issue changes. A second theme is around the removal of ligature points. Again, there's a similar pattern of policy and guidance evolving over time. So the aim to manage ligature risks to ensure the safety of patients is reflected in early policy. Later guidance, such as that issued through patient safety alerts, highlight the identification of new risks that providers must now respond to. More recent policy has been associated with national support for improvement. The third theme is on reducing the need for restrictive interventions. Here you can see that restrictive practice is a key feature of NICE guidelines around delivery of inpatient care, and there is associated guidance on reducing restrictive practice. Commissioning for Quality and Innovation is a framework which links key national targets to additional payments. So you can see this scheme being used to incentivise work to reduce the use of restrictive practices. Similarly, requirements to implement approaches to reduce restrictive practice as part of the mental health units of force legislation are reflected within the NHS Standard Contract, which outlines priorities for providers of NHS funded care. As the COVID-19 pandemic falls within the inquiry's timeline, we've also pulled out some of the policy and guidance relevant to inpatient care in particular. As you can see, the guidance was issued at pace, and many of these documents were updated in a short space of time as needs and the situation changed. These policies primarily relate to the operational requirements of inpatient service, of mental health services, and particularly inpatient services during the first year of the pandemic. This includes organisations of wards to separate patients with and without COVID-19 and to monitor the physical health of these patients with appropriate arrangements to transfer to acute hospitals if their condition deteriorated. During this period, hospitals sought to discharge as many people as possible. Subsequent guidance seeks to guide discharge processes, as well as following up and ensuring there is appropriate support for those who are discharged or deemed to be at high risk in the community. Finally, there is reinforcement of guidance more widely on visiting for hospitals. Although major strategies and plans have often include suicide prevention, there have also been a number of dedicated suicide prevention strategies. In 2000, national policy set an ambition to reduce rates of suicide by a fifth. At the same time, the National Service Framework for Mental Health made suicide prevention one of its core standards. This was followed by a National Suicide Prevention Strategy in 2002. One of the core elements of the strategy was putting learning into practice from the National Confidential Inquiry into Suicide and Homicide in Mental Health. The National Confidential Inquiry had identified 12 points to save the service, which influence how safe an inpatient service is and the actions that can be taken to reduce the risk. This document has been updated over time, but remains a core resource for reducing risk of suicide. The next suicide prevention plan was published in 2012. This looks at actions across government, but again focuses on reducing risk of suicide within inpatient settings, which was identified as a high-risk group. It required local areas to develop suicide prevention plans. The next key point is the National Mental Health Strategy, the 5-year forward view, which sets a new target to reduce the number of people taking their own lives by 10%. This is followed in 2018 by an announcement by the Secretary of State for Health of a zero suicide ambition for mental health inpatient services. Each mental health trust was required to develop a plan to implement the ambition of zero suicides, and funding was made available for staff training and to develop a model to better learn from suicides. In the same year, NHS England announced that the National Confidential Inquiry will be working with all sustainability and transformation partnerships to improve quality and safety within mental health services. Finally, we have a new suicide prevention strategy in 2023. Again, there is focus on inpatient settings and the need to follow up people within 72 hours of discharge from hospital to reduce risk of suicide. Once again, it's worth noting that there is an overlap between suicide prevention policy and the focus of policy on inpatient care, such as on the removal of ligature points and efforts to reduce people who go absent from the ward without leave. The National Confidential Inquiry into Suicide and Homicide has collected data on deaths by suicide to identify trends and disseminate learning since 1997. Their analysis shows that there has been a fall in the rate of patient suicides, that is, people in contact with mental health services in the 12 months prior to death, between 2000 and 2010 and from 2011 until 2021. This takes into account the overall numbers of patients, which has increased during that time. However, there has been little change in the trend in recent years. There is a similar picture with inpatient suicides, showing a long-term downward trend over the period in the rate of inpatient suicide, and again taking into account numbers of patients. We're now going to look at legislation which underpins the delivery of care and that defines roles and requirements in relation to regulation and accountability. The Mental Health Act 1983 covers the assessment, treatment and rights of people with a mental disorder. It is the legal framework for detention of people with a mental disorder in hospital. In 2003, the Delayed Discharges Order for Mental Health Care placed a new requirement on NHS bodies to notify local authorities of patients likely to need community care on discharge. This sought to speed up discharge from hospital and ensure people received appropriate support in the community. The Mental Capacity Act was introduced in 2005. It provides a framework for decision-making on behalf of people who may lack the mental capacity to make their own decisions. The Mental Health Act was then again updated in 2007, with key changes including a simplified definition of mental disorder and a new appropriate medical test which limits the ability to detain someone unless medical treatment appropriate to the person's medical disorder is available. Other changes include the introduction of community treatment orders, allowing patients to be discharged under supervision subject to conditions, which, if breached, could result in recall to hospital, and the introduction of deprivation of liberty safeguards for people who are not detained in hospital but lack the capacity to consent to treatment or care while they're in hospital. The Care Act in 2014 amended Section 117 of the Mental Health Act of 1983. Section 117 provides a right to aftercare services following detention in hospital for mental health treatment. The changes extended those rights to support, taking into account the wider needs of an individual beyond those which were directly relevant to the disorder for which they were admitted. The next piece of legislation makes further amendments to the Mental Health Act, amending Section 136, which allows the police to take a person to a place of safety for assessment. The legislation reduces the maximum length of detention from 72 hours to 24 hours. The final act in this section was introduced with the aims of reducing the use of force and to ensure accountability and transparency around the use of restraint and seclusion. The Act requires mental health units to identify a responsible person to ensure the organisation complies with the requirements of the Act, have appropriate policies in place, and to publish data on how and when physical force is used. This second slide pulls together key legislation which impacts on accountability. The first is the Coroner's Act. This provides a legal framework for when the coroner should be involved and their role. This Act was updated in 2009, including a legal duty to investigate the deaths of people who were detained under the Mental Health Act. In 2012, case law clarified that the duty of NHS to protect mental health patients from risk of suicide also applies to those who are admitted to hospital on a voluntary basis. In 2014, regulations established a new set of fundamental standards relating to the quality and safety of care that all providers must meet, and which would be used as the basis for regulation by the Care Quality Commission. This was updated a year later, requiring registered providers to deliver care in a safe way that avoids reasonable harm. It also included new measures to ensure appropriate information sharing to support the delivery of direct care. The final piece of legislation I want to draw attention to are regulations which require medical practitioners to notify the coroner of a death where a doctor suspects it was due to drugs, medication, treatment, trauma, self-harm, neglect, otherwise unnatural causes, and during state detention. In this next section, we're going to talk more about regulation and accountability. There are a number of arm's length bodies who play a key role in regulating NHS organisations and holding them to account. The Mental Health Act Commission existed between 2000 and 2008. Its role was focused on reviewing use of the Mental Health Act. The Commission investigated complaints made by detained patients about matters that occurred whilst detained and complaints about the use of the Mental Health Act in respect of a detained patient. In general, it reviewed complaints that had been subject to local resolution as a basis to use its own investigatory powers rather than undertaking investigations of complaints itself, and it proceeded only when it was likely to uncover new evidence. The Commission also had visiting powers which it used when potentially serious issues were identified through complaints. In addition, the Commission received notifications of deaths of detained patients. Unnatural deaths and natural deaths where practice issues are identified were the subject of a review to understand whether good practice, as defined by the Mental Health Act, was followed and ensure lessons were learnt. Inspection and regulation of healthcare providers has changed over the years. In 2000, the Commission for Health Improvement inspected healthcare providers and could offer recommendations for improvement, while the National Care Standards Commission was responsible for regulating independent providers according to a set of national care standards. In 2004, these functions merged to form the Commission for Healthcare Audit and Inspection. However, the Commission's role remains to inspect NHS providers and make recommendations while regulating independent providers. In 2009, the Care Quality Commission was established. It took on the roles of the Commission for Healthcare Audit and Inspection, in addition to the roles and functions of the Mental Health Act Commission. The Care Quality Commission, or CQC, has additional powers which enable it to issue warning notices and set out improvements in care a provider must make. It can place a provider in special measures and closely supervise the quality of care. And it can also issue providers with fines and prosecute cases where people are harmed or placed in danger of harm. In 2014, CQC became responsible for regulating new requirements around duty of candour, which requires organisations are open and honest with patients when things go wrong. In addition, CQC was made responsible for assessing that directors meet requirements such that they are fit and proper for their role. In 2000, NHS trusts were accountable to the Secretary of State for Health via health authorities and subsequently strategic health authorities. With the development of NHS foundation trusts came greater financial autonomy. Monitor was established to license NHS foundation trusts, and regulation particularly focused on governance and finances. The role of licensing NHS trusts, foundation trusts and independent providers is now held by NHS England. Finally, there are arm's-length bodies who play a role in safety and investigatory functions. The National Patient Safety Agency monitored patient safety events in NHS-funded care with the aim of learning about adverse incidents. It did this through collecting and analysing information on adverse incidents, sharing learning and working towards targets around specific risks. The function merged into NHS England in 2012. Finally, the Health and Safety Investigation Branch was set up in 2017 to conduct independent investigations into patient safety concerns in NHS-funded care. The organisation was succeeded by the Health Services Safety Investigations Body. Both organisations conducted national investigations with the aim of identifying factors which have contributed to poor safety and make recommendations to reduce risk and improve safety. The following organisations are all non-NHS organisations but play a key role in regulation and accountability of health and care. The General Medical Council, Nursing and Midwifery Council and the Health and Care Professionals Council are all regulators of professionals. They set standards of competence and conduct, check the quality of education and training, maintain a register of professionals and investigate complaints and where there are concerns of misconduct or competence, among other grounds. Concerns which are subject to fitness to practice proceedings involve a formal investigation and are adjudicated by a tribunal or panel set up by the regulator. The Health and Safety Executive enforces the law on health and safety and has the power to bring criminal prosecutions. There is an agreement between CQC and the Health and Safety Executive about who prosecutes in relation to health and hospitals. The Parliamentary and Health Service Ombudsman investigates complaints against NHS authorities or trusts when people have exhausted all other routes of complaint. Finally, the Coroner's Service investigates deaths which have occurred as a result of violence or unnatural circumstances or that have occurred in custody. From 2009, this included deaths of people detained under the Mental Health Act. The final slides in this section cover some of the key policies and guidance relating to accountability and regulation. I want to start by first bringing to attention the two codes of practice. These are statutory guidance which accompanies the associated legislation and provide guidance for professionals on applications of the Act in practice. They've been updated at regular intervals to reflect updates to the legislation, policy, case law, and professional practice. Within these slides, there are a number of tools which government and NHS bodies use to define what providers of NHS care should prioritise. One is the operating framework, which sets out the planning, performance and financial requirements for NHS organisations. In 2007, the operating framework required trusts to comply with policy on addressing issues with mixed-sex accommodation, which was issued in 1999. It also requires Primary Care Trust, who commissioned care at the time, to ensure implementation. This is picked up again in the operating framework for 2010-11, but moves towards the elimination of mixed-sex accommodation. Another route of guidance has been through the National Patient Safety Agency. In 2009, the Never Events Framework, which sets out serious events deemed to be preventable, included suicide using non-collapsible ligature points. It required trusts to monitor their incidents, and trusts were provided with advice to reduce the risk. The following year, the National Patient Safety Agency published a national framework for reporting and learning from serious incidents requiring investigation. This aims to ensure consistency in definitions, roles and responsibilities in relation to reporting and to clarify legal and regulatory requirements. In the same year, registered providers were required to notify CQC about any events which could be perceived as a risk to compliance with their registration requirements. This included reports about serious incidents and deaths. The operating framework in that year also reflected an expectation that NHS organisations eliminate mixed-sex accommodation. Further guidance was issued in 2012, which requires all NHS trusts providing specialist mental health services to report all apparent or actual suicides of people who are in their care at the time of death. In 2015, the Department of Health also issues guidance to ensure that the NHS is compliant with Article 2 of the European Convention on Human Rights. The guidance states that NHS organisations should consider an investigation to examine the cause of a serious incident or multiple serious incidents that could indicate systemic failures to protect life. In the same year, following changes in the legislation, professional regulatory bodies issued guidance on professional duty of candour. This was done through joint guidance for the GMC and NMC and through a revision of professional standards for professionals registered with the Health and Care Professionals Council. In 2016, the National Quality Board published its first shared commitment to quality. This is a nationally agreed definition of quality which is held across all national bodies. It is intended as a guide for professionals leading work to improve care and includes safety, effectiveness, positive experience of people receiving care, that organisations are well led, and use of resources is sustainable and equitable for all. Similar to the operating framework, the Clinical Commissioning Group Assessment Framework formed a tool indicating areas for prioritisation by commissioners and was used as part of monitoring performance. In 2016, the framework included an indicator on reducing numbers of out-of-area placements for acute mental health care. Moving on to 2017, there are two pieces of policy and guidance I want to draw your attention to. The first is a written statement to the House of Commons by the Parliamentary Under-Secretary of State for Health, which outlines the expectation that all deaths of patients under the care of child and adolescent mental health inpatient services would be reported to ministers, providing a line of visibility and accountability. At the same time, the National Guidance on Learning from Deaths framework was updated, requiring trusts to develop and publish a policy on how they respond to and learn from deaths of patients who die under their management and care. This includes requirements around governance and processes, staff skills to effectively review and investigate deaths, and policies for engaging with bereaved families and carers. In addition, trusts were required to collect and publish data on deaths. A further tool, the NHS Oversight Framework, describes how NHS trusts, foundation trusts, and integrated care boards will be monitored on performance. In 2019, this included an explicit focus on mental health out-of-area placements, along with quality of data submitted at a national level, with regional NHS England teams reviewing performance and providing support where needed. Finally, we jumped to 2022 with the publication of the Patient Safety Incident Response Framework, which requires all providers of NHS-funded care to create a policy that describes the systems they have in place to learn from and improve on patient safety incidents. In addition, the National Standard Contract, which is issued each year to NHS providers, introduces a national quality requirement that 80% of service users under mental illness specialities are followed up within 72 hours of discharge from inpatient care. However, at this point, this does not apply to specialised mental health services commissioned by NHS England. The final slide I'm going to cover in this section is around policy on leadership, because this outlines expectations and it is part of regulation. The first leadership framework was published in 2002. The framework provides a consistent approach to leadership development, focusing on values and behaviours. This is updated over the years to include clinical and managerial staff and focusing on core competencies. In 2014, CQC and Monitor both started to use frameworks to assess leadership and governance of providers. In CQC, this was the well-led framework. CQC used a number of key lines of inquiry to guide their inspection process. The well-led framework had 5 key lines of inquiry, including vision and strategy, governance arrangements, leadership and culture, patient and staff experiences, and continuous learning and improvement. At the same time, Monitor adopted an aligned approach as part of supporting and assessing trusts applying to become a foundation trust. This was updated in 2017 and aligns between regulators. It's also expanded to cover 8 key lines of inquiry. It forms part of the oversight process for trusts and foundation trusts, which require trusts to conduct developmental reviews of their leadership and governance and report on their findings. In 2019, there are 2 new requirements. The first recognises the importance of diversity and representation of minoritised groups within senior NHS leadership. This includes the use of the workforce race equality standards to support improvement. The second is freedom to speak up. The policy includes structures and roles which aim to improve the ability of staff to speak up about concerns about patient care. In 2021, new guidance focuses on the role of integrated care systems and the need for distributed leadership across systems and the organisations involved. Integrated care systems are required to agree a local plan for clinical and care professional leadership across all integrated care system partners. Finally, in 2022, NHS England issued a Code of Governance for NHS provider trusts. The code applies to both NHS trusts and foundation trusts, which are required to comply with each of the provisions of the code. The final section picks up some additional areas, including mental health data and funding. This slide takes us through the availability and development of data during this time period. In 2000, there was a basic data set on mental health and learning disabilities. In addition, data was captured on the number of people detained under the Mental Health Act. Both data sets were managed by the Department of Health. In 2003, following the setup of a minimum data set, it was mandatory for all providers to submit data. Another notable data set was the Count Me In census, which captured all patients in a psychiatric unit at one time point. The data included ethnicity, so comparisons could be made about experience of care. It also included all NHS and independent mental health services. This survey ceased in 2011. In 2009, the NHS Workforce Statistics dataset was established. This captures numbers of NHS hospital and community health services staff working in NHS trusts. The next isn't a dataset as such, but to note that the Health and Social Care Act 2012 provides the Health and Social Care Information Centre, which collects data for the NHS, with statutory powers to require data from providers of health and care services as part of their contract. If we jump down to the bottom row, in 2013, the Mental Health Dashboard is established as part of the 5-year forward view for mental health. The dashboard brings together a series of published measures to monitor progress against current strategic policy objectives. It also includes data on funding. In 2014, the national minimum dataset is expanded to include people with learning disabilities. This dataset is subsequently replaced with the Mental Health Services dataset, which also replaces KP90 data on people detained under the Mental Health Act. The data allows for more detailed analysis to support service improvement and monitor performance. It was also designed to support implementation of access and waiting time standards. In 2018, NHS England developed a dashboard of quality metrics for specialised services with the aim of providing assurance on quality of care. Finally, in 2019, the NHS Long-Term Implementation Plan sets out requirements for all mental health providers to improve the quality of data submitted to be measured through a Data Quality Maturity Index. There's been no consistent data set which tracks funding for mental health care. As a result, it's hard to give a pattern of funding over the time period for which the inquiry spans. Instead, the following two slides outline some of the key mechanisms for funding in healthcare, including mental health, and key points of investment with a focus on inpatient services. I want to draw attention to three funding components which existed over the length of the inquiry period. The first is national funding, often for programmes of work for which funding is then allocated to providers of care or via commissioning bodies. Mental health services have traditionally been funded through a block contract. This is a payment made to a provider to deliver a specific, usually broadly defined service. How block contracts are calculated varies and can be set through a measure of patient need or based on historical spend. NHS organisations are set efficiency targets on an annual basis. Cost improvement programmes set out how each organisation is going to save money while maintaining the quality of services it provides. There have been a number of additional components and changes over time. The first, in 2009, is the introduction of Commissioning for Quality and Innovation, or CEQIN. This is a payment framework which enables commissioners to reward NHS providers by linking a proportion of the provider's income to achievement of a set of quality indicators. The indicators include national goals, which focus on key priorities, and local goals to be agreed with commissioners. In 2012, the NHS brought in a new mechanism which aims to support the development of a payment by results approach in mental health and supporting a move away from block contracts. This was closely followed by the introduction of new payment approaches, which had developed over time but largely offer a wider range of options for procurement. In 2016, the Mental Health Investment Standard was introduced. The standard aims to increase investment in mental health services across England. The investment standard required all clinical commissioning groups to increase investment in mental health services in line with their overall increase in funding allocation each year. Commissioners are audited on their achievement of the standard. Finally, as mentioned previously, NHS England started to delegate budgetary responsibility for commissioning of some specialised services, which included low and medium secure mental health services, children and young people's inpatient services, and adult eating disorder services. Often national strategy and policy comes with additional investment. Those policies direct where funding can be invested and to what purpose. This slide highlights funding which has been targeted towards improving access and quality of care in inpatient services. The NHS Plan and National Service Framework in the early 2000s came with significant investment, a proportion of which included expansion of bed capacity and specific services. In addition, there was investment to remove dormitory accommodation from inpatient care. In 2014, investment supported expansions in bed capacity for children and young people. The 5-year forward view, 2 years later, also expanded capacity, but specifically for perinatal mental health in the form of mother and baby units. This ensured that capacity was available across the country. In 2019, the long-term plan provided additional investment in activities and interventions on inpatient wards to improve the therapeutic offer and for expansion of the workforce in mother and baby units. In 2020, there was additional investment in replacing dormitory accommodation as part of the suicide prevention strategy to develop local suicide prevention plans. However, in addition, COVID led to additional measures to manage the changing picture of care during this period. There was an uplift in the block contract value of mental health providers, and systems were instructed to recognise additional costs incurred in responding to COVID. Finally, additional funding was made available to support post-discharge support for mental health patients during winter. In 2021, the government announced additional funding to expand mental health services as part of the recovery from COVID, which included further funding to provide enhanced discharge support from inpatient mental health care. Finally, it's worth noting that the Commissioning for Quality and Innovation payment framework has been used consistently since 2016 to improve quality of care in inpatient settings. That concludes the content of this presentation and the seminar. I hope we've provided you with a better understanding of the context for the delivery of mental health care over the last 24 years. Thank you for listening.